Asmita, are you there? Good evening, everybody. We are here again after 1 week extra break because of unavailability of the radiologist. And today we have got 4 cases. And I'll start.
Wait, Asmita. Unavailability of radiologists because they were busy in their national conference. It's
Sure.
very
I'm
hard
so
to not
sorry. I'm
just
so
like that.
sorry. I have to tell the full sentence that they were all busy because of their
Thank
national
you.
conference.
Ah,
And today also many people are in ERS, but we are still running our show. And let us start with the first case. I'll start sharing my screen. I forgot you are there to answer me back.
તો કાંઈ પણ બોલી દેવાનું આપણે.
That is what. Yeah, બહુ ખરાબ આદત છે. So let us start. So this is one case number 1. She is a 67 years old lady who presented to me with she has type 2 diabetes, systemic hypertension, coronary artery disease, and hyperuricemia. She had dry cough for 5 months, which is aggravated in supine position. She was labeled as GERD and was treated for the same because of positional cough. She started having dyspnea on exertion also for last 5 months, but it was not more than grade 1. She also complained of small joint pain for last 1 year. COVID, which was mild COVID, managed conservatively. She had 4 lovebirds at home for last 10 years, and it was outside her home. There is where she is staying, the next house, there was marble cutting going on. Earlier, they were not cutting marble in the home, but for last 2 to 3 years, they were cutting marbles inside the home, and she was exposed to those dust. She's telling that that might be the reason. The family members also thinks that the same way. So there is 2 exposure history. One is marble cutting, one is lovebirds. Her other vitals and everything was fine. She had bilateral crepitations, and her creatinine, SGOT, SGPT, CBC, everything was normal. HbA1c was bad, around 7, and she was on very stiff dose of insulin, 40 and 22 units of human mixed start. That is what the worrisome thing was when I saw her first time. And her FVC was 70%, FEV1 was 82%. DLCO and 6-minute walk test was not possible. She was continuously coughing when I saw her. I have to admit her for the management of cough. And she had tracheobronchomalacia kind of cough. And she can't even stop coughing, like not even one sentence she can tell me. So DLCO was not done. Even at the time of discharge, I could not do. Bronchoscopy was also difficult. Now, RF factor was negative and NT-CCP came 21.4. And I'm yet to ask Mithun what do you interpret by that. Other than that, the workup was negative, ANA was negative. This particular thing I have asked Mithun, and he told this is non-specific because everything is coming positive. By now, we also know that if you have more than 10 bars positive, that means it is non-specific. So myositis profile, he told just ignore it. And now I will just stop sharing my screen and Aparna can take over.
Are you able to see my screen?
Yes, we can.
Yeah. So these are the inspiratory and expiratory images. I don't have proper HRCT. These are little thick sections. But what we're seeing is there is diffuse involvement, both lungs, upper lobes, lower lobes, central, peripheral, everything is involved. And we are having a lot of mosaic attenuation. And when we see the inspiratory, expiratory, there are these kind of lobular areas of air trapping also. Fibrosis part, there may be a minimal amount of fibrosis where we can see some mild traction bronchiectasis, but the fibrosis part is not predominant. Little bit of reticulations and traction, but more of ground glass and air trapping and this like 3 density sign and mosaic attenuation. That is the predominant pattern. Lymph nodes were just small, not significant nodes. Pulmonary artery is not dilated. There is definitely increased collapsibility of the trachea. There is it's quite, the posterior wall is getting quite anteriorly displaced on this expiratory view. So it's like an expiratory dynamic airway collapse.
Yeah.
which may be correlating with the history that you said, like tracheobronchomalacia, like cough you said. So that is kind of correlating with that. So with this pattern that it is diffuse involvement, central peripheral and air trapping and everything, it's looking more like a hypersensitivity pneumonitis. Predominantly, it's not really fibrotic. The other doubt was about the marble factory and all that. So nothing really looking like silicosis on this.
Okay.
So I would say maybe more like hypersensitivity pneumonitis. There's one small area of like a consolidation in the left upper lobe. Maybe we can just follow that up.
Okay. So my doubt is this bronchiectasis is a traction bronchiectasis or it is a reversible bronchiectasis which happens in the background of consolidation?
I think only after we follow, we'll know whether it's going to resolve.
Yeah. Sure. Okay. So if you can stop sharing, I'll show the biopsy. Yeah. So as she shown, we could see that the bronchoscopy was also very difficult because she had excessive dynamic airway collapse and we had to put her on CPAP and convince her that she has to use it. Anyway, I was able to do a biopsy without creating pneumothorax. And Ritu madam, if you can just describe, this is the one slide. Do you want to say anything?
Yeah, am I audible, please?
Yes, you are audible.
Okay, so this is a very nicely taken endobronchial and transbronchial lung biopsy. And at this slow power itself, we can see that there is good amount of cellular interstitial pneumonitis. There is some amount of air trapping. And in addition to the cellular interstitial pneumonitis, there is fibrosis also of the interstitium, which can be seen. We can see this in the next higher power. If we go to the next image. We'll see that there are here again the air trapping is more. This is okay. The air trapping is more prominent here, and these are the spaces which are showing air trapping. And in this further higher image, you can see that there is an aggregate towards the right side corner. There is an aggregate of lymphocytes and histiocytes and some larger looking cells and leading to an ill-defined granuloma formation. But the next image which is there, the next picture which is there is showing more pink-colored, homogeneous widening of the interstitium. So with this, this is indicative of both fibrotic as well as mixed cellular inflammatory kind of a pattern which is there. It's an interstitial involvement. We can see some lining by some hyperplastic type 2 pneumocytes, but the predominant picture is that of mixed inflammatory and fibrotic type of interstitial pneumonitis, and that one ill-defined granuloma which we saw. This was confirmed. This is confirmed by the next slide, which is with the Mason's trichrome stain, where you can see the dark blue, which is showing the fibrosis which is there in the interstitium. And the next image is showing nicely the cholesterol granuloma. That means these are the multinucleated giant cells, which with this, this large empty area is there. That is the cholesterol crystal, which comes out as a negative image on histopathology, and it's marked by the orange arrow. And again, the next image, I think the last image which is there is also showing this large multinuclear giant cell with the cholesterol granulomas. Now, the differential here would be because cholesterol granulomas can be seen in both NSIP and in hypersensitivity pneumonitis. So, therefore, the histopathology differential here would be first a fibrotic hypersensitivity pneumonitis, and the second one would be to rule out on radiology. Would be an NSIP pattern, mixed cellular and fibrotic.
Yeah. So my questions to the panel will be, do we have a consensus diagnosis? Then I have started her on steroids, but the family came back to me for the biopsy report and they told she is becoming very weak and all, and her sugars are going haywire, that sometimes hypo, sometimes hyper. So I'm worried about continuing steroids. So should I add right upon MMF or should I wait? And because there is a biopsy slide which is showing fibrosis, should we wait or always we want to label it as a PPF? And that's it, I think. Yeah, biopsy I already did. Mithun, there was anti-CCP 21.5. Is it significant? I'll show you that slide. Did you see that?
No, I joined little late.
Yeah,
Little
so
late.
I'll just show you that particular, because that thing I didn't ask you. I asked you about the this thing about our myositis panel. I will show you both. So yeah, this was her myositis panel.
That is not significant.
Yeah, that you told me that day. This is what her profile is.
Anti-CCP, if it is more than 3 times of the upper limit, here the upper limit is 17. Our cutoff is 17. If more than 3 times of upper limit is considered a significant positive. If there is no arthritis, this is not significant.
She had small joint arthritis and she had hyperuricemia and she was treated for the same. Now she is a diabetic and for many years diabetic. Her stiff insulin requirement. I believe there might be many reasons for hyperuricemia, and maybe she improved with those small joint pain, improved with those drugs. So I believe we should go for that, right? Rheumatoid arthritis negative and CCP borderline positive, I could ignore. What do you say?
You can ignore. You can ignore.
Yeah. So I will put the questions and maybe the panels, Rajan sir or Harjit Singh Dumra or Murli Mohan sir, I'm not sure. I can't see. I'll stop sharing and then see. Yeah.
Yeah.
You stop the audio of the other device, sir.
There's no other device.
There is, you are joined from 2 devices, sir. I can see. No, you are muted now. You are muted, sir. There is another device, maybe mobile or something.
You can ask the administrator to delete that other one, no, of Sujit. They can.
Manish?
So, yeah, just delete the other Sujit Rajan. No?
I don't. In fact, I don't know how it's coming because my phone is off.
That person can delete, can remove you from there.
You have logged in from 2 devices. That's what is showing.
Somehow, so. The admin can actually remove a person and they can remove the one where your picture is not shown.
Yeah. Yeah, my Gosh.
Okay, now you try. Now
Better?
you try, sir. Yeah. I did it. I did what the tech people didn't do. Okay.
Sorry about that.
No problem.
So I don't know whether I would have biopsied the patient with lovebirds in that kind of a CT pattern, but you did. And now looking at the biopsy findings, I think there is nothing to suggest. Were there any granulomas at all, Ritu?
Yeah, there was some in the image which you could say were ill-defined.
Yeah, giant
Poorly
cells.
formed. Poorly formed. Yeah.
So I would definitely put this as fibrotic hypersensitivity pneumonitis and no other diagnosis here, Asmita.
Yes.
Unless you thought clinically there was anything else, because this fits into. I'm surprised she couldn't do a DLCO. She had a decent vital capacity.
No. She was coughing, sir, for holding breath. Yeah. So she was continuously coughing. Yeah.
Sure. And her walk test
Walk test also they could not do because she was coughing. Then it will be like in OPD, it will be a big trouble. One person who is coughing, walking around.
Sure.
Yeah.
So I would work with a fibrotic HP diagnosis. What's your second question?
My second question is, because she has got very stiff requirement of steroids, should I add upon MMF right away or should we wait?
Why do you say she has a stiff requirement of steroids?
40 units and 22 units Mixtard and Lente in the night of 12 units.
No, that's insulin.
Yeah,
That's
insulin.
a
Sorry.
stiff requirement of insulin.
Yeah, insulin. Sorry. Yeah.
Right. So what's the question?
So should we add a steroid sparing agent right away? Because she doesn't have any, like now also they are telling that sometimes it is 300, sometimes it goes to 70. So they are also worried about the, like because of steroids, the way sugars are going.
How much steroid are you giving her, Asmita?
I started her on 40 milligram 2 weeks and then they came for the report. And that is why when I say.
Yeah. I mean, if it's not made has it made a radical difference to her symptoms or cough or anything?
Cough has subsided. I could not explain the other complaint which they started telling me she has become very weak. That is why I asked Mithun about myositis panel, which he told is negative.
Yeah, so I think that you bring down the steroid dose and get mycophenolate on as soon as possible, because if 40 milligrams has treated her, reversed her cough.
Cough is reversed.
I would get that down to 30. 20 every week, probably bring the dose down and get her on the full dose mycophenolate, especially with her diabetes.
Okay. And the last question was...
She's not young, she's 67.
Yeah, she is old.
Be careful,
And the last question was, because even biopsy proven fibrosis, Aparna was also, there was a doubt about some areas of fibrosis. So usually this particular discussion happens in our MDM that we add upon, there is a role of antifibrotic only in progressive fibrosis, right? So you people always suggest me to wait for PFT and see for the progression. So we should follow that policy here also.
I think so. Otherwise, you'll end up putting every fibrotic ILD on an antifibrotic, which is really not advisable.
So 3 months PFT and to take a call on antifibrotic. Is it right?
That's right. There is no rush to do that because she'll be lifelong on it. I mean, she's not young, but having said that, even at her age, why would you want to commit her to a lifelong drug in a hurry?
So MMF, we have to add that I'll do. Harjit, you are there, Dumra? Dr. Dumra?
Harjit is there, but he's somehow, he's there but not there. So
even Sajal told me that he is going to join. He also didn't join. If you can drop a message to Sajal.
I will.
Okay, I'll move on to the next case. We are already 5:25. So this is a 69 years old man who is hailing from Maldives and retired from military. He also had multiple comorbidities, diabetes, dyslipidemia, and obstructive airway disease. He is using inhaler. Now, he had an outside CT scan, and on basis of which he came for second opinion to us. This was his complaint when he came to me. Intermittent episodes of cough with whitish expectoration for 1 month. Dyspnea, MMRC grade 2. He was tachypnic when I saw him. But no other connective tissue disease illness. He was a reformed smoker. He stopped smoking for last almost 3 years. His vitals were stable and his other investigations were fine. I don't know what is problem in my computer, but this particular slide comes like this. Now anti-CCP is again 20. Other than that, there's something wrong with our CCP, Mithun. And ANA, RF factor, CA 9.86, everything was fine. This particular thing, Mithun, you think anything significant?
These are actually very low positive things, and it is unlikely to be significant. centromere, PML. Although if it comes as a 2+ or more than that, should take it as significant. In this, it is doubtful. We can say borderline positive. Anti-CCP definitely not significant.
Not significant. Okay. So this particular thing, I would like to have a look on CT scan first, and then I will tell you what happened. Yeah, Aparna.
Yeah, you're able to see, right?
Yes, we are.
Okay. So this CT is from 10th of July. And what we're seeing is, again, there's diffuse involvement. There's diffusely mild bronchiectasis is there, mild diffuse bronchial wall thickening also. And many areas of peribronchovascular ground glass and small consolidations are there diffusely in both lungs. There is some kind of hyperinflation of both lungs. If you see the coronal, we can see. So that is correlating with the COPD and the smoking history that you're saying. So he is having some background obstructive airways disease with bronchial wall thickening and mild cylindrical bronchiectasis. Some areas are looking like some focal scarring also because of mild traction bronchiectasis, and lot of periBronchovascular ground glass and consolidation.
Yeah. So yeah,
yes.
The problem was now this particular CT was labeled outside, like it was done in July. The reason I didn't repeat is his X-ray and my X-ray was correlating. So I didn't find any benefit of repeating one more CT scan. So it was a good quality CT. Then the examination wise, he had clubbing and I could find bilateral crepitation. So my doubt was, am I dealing with something coexisting ILD or something? But surprisingly, when I did bronchoscopy, it was showing purulent secretions starting from vocal cord, trachea, everywhere. So this particular peribronchial ground glass opacity, which I was confused about, is it ILD or not? That was the only reason that I have put this case in discussion. So because there are something called bronchocentric and all those things. So how do you define this particular? Because that is why I put this particular CT scan. So if we can go to HR and just explain that, do we think this ground glass opacity, which was surrounding, after seeing bronchoscopy, I decided against doing biopsy because I felt that it might be just surrounding area of infection or something like
just before I go into that, before I forget one point, in the supraglottic area also there is some mild narrowing and some edematous mucosa. But you would have seen that on the scopy, I guess, and maybe that was
he had a bad OSA. Actually, that's what I felt, because like when we do bronchoscopy and all, I'm not telling that is the best case to diagnose OSA, but we sedate the patient and we can, because I do under conscious sedation. So most of the times I don't remember I saw any obstruction there.
It's just looking like edematous and bulging. So that's just, I wanted to mention that. But if there was anything, definitely you would have seen, I guess. Yeah. I think basically all these findings will have to be taken in the clinical context. So infection is definitely possible. Resolving infection is the other thing. Organizing pneumonia will be another differential. And because there is some mild bronchiectasis, whether it is like some kind of airway-centered interstitial fibrosis also is possible. I think we'll have to, you would have given antibiotics. We'll have to see how it resolves and what happens, I think, and then decide.
Sure. So that was the reason that whether this particular CT falls into ILD category or not. Actually, by looking at CT scan, to be very honest, I didn't feel this was bronchiectasis. Well, it doesn't fall into classical now because it is central, isn't it? It's not going into periphery also, like most of the thing.
No, like if you see these areas, you can see the mildly, see this. These are the ones. Yeah, but it's more central, like.
Yeah, that was, and then because there was a ground glass opacity surrounding it, that made me confused, and I was like, okay, this is ILD kind of. So I have put this particular discussion because of that only, that this kind of CT scan should we take as ILD or not? And definitely, I believe that repeat CT scan is required to see whether it resolved or not, or I have to go after chase it, right?
Yes. And
But
like
are there
history-wise also, there was nothing for infection, no, ma'am? Like
No,
initially you
counts,
didn't say
everything is
anything.
fine. No.
Yeah,
I
how to
felt it
explain
was.
that? That also I
Yeah,
can't understand.
I was shocked to see his bronchoscopy images, which was flooded with secretions. Actually, I was charged to do biopsy, but I didn't do biopsy because I saw this much secretions. I thought it is not a good idea to biopsy when the patient has got this much of infection. He has to become all right before that, and I might do repeat imaging to see what's going on. So that is why it was just culture, but cultures are all negative, sterile. Nothing came out of it, but secretions were there. Significant purulent secretions starting from vocal cord to both the bronchial tree. I sucked it out and cleared it in. And then he left for Maldives. I don't know what happened after.
Did you get anything on the cultures, Asmita?
Yeah, it all came negative, sir. Everything negative. MTB panel, everything negative.
But there are some, Aparna, there are some nodular shadows, right? Ill-defined on the left side
Nodular,
towards the periphery. I thought like an infectious bronchiolitis, upper lobes.
not really, sir. It's the
No.
same things that whatever is peribronchovascular ground glass,
Sure.
similar things.
And with purulent secretions coming out of the scope, I would have thought this was likely to be an infection, atypical maybe, or would this fit into this won't fit into a eosinophilia pattern, right? And your differential counts did not show any eosinophilia.
No. Usually I send fungal culture also, but no, I didn't see eosinophilia. His IG was not elevated. I didn't show you the PFT report also, right? I'll show you. It was restrictive pattern. 72 and 80, I believe.
But he had no fever, Asmita.
He didn't have fever. His counts and everything also were normal. I'll just show you. So this particular slide is so bad. So this is his CBC, everything was normal, sir. That is what I remember. And then he is diabetic, so he was on this medicine, ICS LABA, and Montelukast was given by that doctor in 72, 74. That is what his FE1, FVC. After I was planning for doing DLC, but after seeing his bronchoscopy, I thought, okay, I'll do it later because he's so having so much secretions and all. So I didn't do that. So the question is it ILD or bronchiectasis? That was the first question, that where should we put it? And do I need to do repeat CT to see peribronchial GGOs get cleared or not? And do we need to repeat bronchoscopy or biopsy for this gentleman, as current FOB was all purulent secretions, and I thought against doing biopsy on that particular time. So if the images are still showing it, we should do, right? That's what you are saying.
Yes, ma'am, for your first question, I think there is definitely an OAD component and bronchiectasis component.
Okay.
And the second question, I think we have to repeat and see, and then if there is
repeat after
residual,
6 weeks.
Yes,
6 weeks, yeah.
But he's taking some antibiotics, no, ma'am? No.
Yeah, I started him on
Okay.
antibiotics.
Yes.
Yeah. Usually I give. Yeah.
Harjeet, your thoughts?
I was not part of the initial discussion, so I just logged in. But what I feel is that, is there a probability of something in the background and then superimposed acute viral insult? Because usually these kinds of ground glass opacities would come up with acute processes. But the secretions obviously should not be a part of that acute process. So he has to have been carrying a background of OAD, which might have flared up leading to secretions. So I was thinking in terms of a background OAD, which could explain the secretions, and he must have landed into an exacerbation, and the ground glass opacities would be pretty acute and fresh.
Yeah, the problem is now, Harjit, this particular CT was taken in July, and I am seeing him in somewhere in August. So there was 1 month gap, and his complaint started for 1 month only. So by looking at his CT scan, I felt, okay, I don't need to repeat. So if it was some viral infection, don't you think it should have gone by that? And purulent secretions unlikely in viral infection. What do you say?
Yes, but if it is 1 month down the line that he has had purulent secretions, then it's possible that the OAD component, which is again difficult to be 100% sure about because the PFT is restrictive. So frankly speaking, with a restrictive loop, I can't stamp it as OAD. there is a remote possibility of him having bronchiolitis, but again, that should have led to some symptoms in the past. So I don't think we have such reasonable justification to label it as background OAD, but the bronchiectasis is not significant enough to explain the volume of secretions. So it's a mixed bag kind of stuff.
So my this particular CT scan now, I felt something going on bronchocentric, because that is bronchocentric is Bhavin sir's favorite, something like which I have usually heard from him. So I was thinking some bronchocentric ILD, not granulomatosis. I was planning to do biopsy because of that, but I didn't do. That was the thing. So only after doing repeat CT we can decide, right?
It definitely doesn't look like a bad bronchiectasis.
I also felt, not typical, na sir, because that all those 4 criteria are not matching, that peripheral tapering and this and that.
How long is the history, Asmita?
1 year. 1 year. He stopped smoking for 2-3 years and 1 year. And this was like outside. Radiologist has reported it as a ground glass opacity, interstitial lung disease. And then I saw clubbing and crepitation, and I got carried away.
Oh, he's clubbed also?
Yeah, he has clubbing.
Okay.
Does he desaturate on exercise?
I know he was.
He's not shown us a DLCO, but does he desaturate on exercise? Because that will give me some leverage to start thinking of an interstitial process.
I don't think I did 6-minute walk test. I'll find out. I'll find out in between.
I would also.
Sorry. No, go ahead. Sorry.
No, I would also probably get his lung volumes done.
Yeah, definitely.
When he settles after this. And I mean, I just thought this was looking like some superadded infection, some infection going on the top of a background airway disease, which is, anyone's guess how bad that airway disease is. But he's been symptomatic since a year, but managing his life. Am I right, Asmita? Just cough, right? Any breathlessness or anything?
So what doctor came to me and told me that he is continuously coughing day in and day out, and that is the reason she brought him to me. And breathing difficulty, he can't carry on his daily activities. He has to stop in between. So it was amounting to MMRC grade 2 to grade 3. And 6-minute walk test, I'm not sure why I didn't do, but I'll check on that. Yeah.
Has he moved to e-cigarettes from tobacco?
I didn't ask that. He told he stopped smoking. Mostly this people, do hookah also, sir.
69-year-old trying e-cigarettes is a little rare.
No, but often they taper from. So I have quite a few school friends who've moved from tobacco smoking, and they're all touching 60. So, 5-10 years here and there, it's okay. So they've all migrated to e-cigs, right?
Okay.
Because they find that you still get nicotine delivery, but you avoid the rest of the stuff that comes in a cigarette. So my question is whether there's an ongoing EVALI-like problem, in all of this, because that can present with all of these features as well. So, you could have a respiratory bronchiolitis component, you can have some lung injury still happening if there is still exposure to any inhalational injury. So just a thought.
Yeah, they are going to mail me. They are going to mail me because his ANA and other reports were awaited. So I will ask it, sir.
Any history of hemoptysis, Asmita?
No hemoptysis, no. In this particular cut, it looks like bronchiectasis. Now, only my problem was why it is not in periphery and only in the center.
So it's not looking a bad bronchiectasis.
Not bad bronchiectasis.
I don't know.
Why at this age? Why should it start at this age? And I had many.
Yeah, here maybe a little freestanding bronchiectasis there in the upper lobe. Yeah. ABPA workup is negative, right?
I'm not sure I sent ABPA workup, but I can do that. Yeah.
And your AFB cultures are pending or are they negative?
So MTB panel includes gene expert and AP smear and AB culture. So this expert and smear has come negative. Culture will come. I till now it is negative.
Because I would be suspecting NTM more than MTB here, if at all.
Okay. Sure. So aspergillus specific IgG I will be sending, and I will be waiting for AFB culture, and I will be asking history of e-cigarettes and repeat CT scan. Repeat CT scan actually I suggested that we should do. And that they told that either they will come back or they will get it done and forward me the images. So we don't have answers. Okay, we'll move on to third case.
The bronchiectasis is a little better defined here on this image here. This
Is there emphysema? It's isn't it, sir? There are some.
Yeah, it's definitely looking hyperinflated rather than.
it's hyper. Yeah.
Okay.
But, it says this patients come like a bolt out of the blue, right? You have one spirometry and you have one CT and a 1-year history. So you have to rewind back to think what's happening here.
No, this particular CT was only because I felt like I could not diagnose bronchiectasis. So I will put it on discussion that I confused bronchiectasis with ILD, and that was the reason that this CT in this case was put for discussion. But now you all agree that it was not that easy, right? Okay. We will move on to next, sir. If you are. Aparna, you wanted to show something or you stop sharing? So I'll show the third images. I mailed you the images. If you could open it, you open it. Shobha madam's cases. Just see.
Yeah, sure.
Okay. Thank you. So we'll move on to third case. Yeah, madam, you can start.
Good evening. Third case is 63-year-old male. He's a native of Kanyakumari in Tamil Nadu, driver by profession, working in UAE, no history of any exposures. Comorbidity is systemic hypertension and diabetes, and he had briefly smoked in the past. And the presentation was breathlessness for 2 years, which was progressive on exertion, no wheeze or any triggers. And there was dry cough since 2 years. And he went to an outside hospital on the 30th of September last year, and he was diagnosed as a fibrotic ILD and started on deflazacort and nintedanib. And it was taken for 1 month, and following which he developed drug-induced liver injury and steroid-induced diabetes. He was admitted and treated for 1 week. Both the medications were stopped and he was discharged. And that was the situation when he came here. He had icterus. His saturation was 97% on room air, and there was no clubbing. There was no feature suggestive of connective tissue disease. Chest showed bilateral crackles. And that was the X-ray on the November 27th, 2023.
Madam, sorry, this patient is Swami Das or Uday Kumar?
This is.
Sorry, I could not hear you.
Swami Das.
Okay. So Swami Das, I have only one image, which is from 27th of November 2023. And this also, I have only the CT thorax, not the HRCT image. So on this, what we are seeing is there are a lot of patchy ground glass densities, and intervening, we are seeing some areas of sparing and probable like geographic areas of air trapping. There is a slight lower lobe predominance, but some upper lobe involvement is also there. In the upper lobes, there is both central as well as peripheral involvement. Some reticulation, some ground glass, and intervening, there are areas of sparing and some lobular areas of air trapping. So I'm considering like whether it could be like NSIP or NSIP OP overlap kind of picture. Okay. There are no nodes and the pulmonary artery is not dilated.
But there was some, cardiac enlargement was there in the X-ray, that's all.
Maybe not much dilated, ma'am. Maybe mildly dilated. dilated. Main pulmonary artery is definitely not dilated.
Okay. So it is looking like NSIP
or NSIP OP overlap.
Kind of. Overlap.
Yes.
Right. Yeah. We went ahead with this CTD workup, I think.
Just stop sharing, Aparna. I'll share my screen. Yeah. Yeah.
Yeah, this was the PFT on December. FVC was 1.03 liters, 30% predicted. DLCO was 11%, and he walked the 360 meters. There was desaturation and severe dyspnea. So that was the picture in December. And yeah, CTD workup is there. I think, yeah. RA factor is negative. ANA 2+ nucleolar, ANA profile is negative, and anti-myositis. If you can just show me the panel result. Next slide is that, I think. Yeah, which showed NXP2 and SAE1 positive. Dr. Midun, you are here. Can you comment on this?
Hi, ma'am.
Hi.
Usually, this myositis specific antibodies, both SAE1 and NSP2, both are myositis specific antibodies. It is said that it should be mutually exclusive. That means if one is positive, other should be negative.
Oh, right.
That's the usual pattern with for myositis specific antibodies. Here, but we can take this, if you take NSP2 as the significant positive antibody, this SAE1 may be a false positive, mild positivity.
Okay.
But NSP2 is associated with myositis, related ILD, and also malignancy.
Right.
Both are.
Yeah. So we went ahead with the PET-CT to rule out malignancy, and malignancy, no abnormal focal or diffuse FDG uptake areas were found on PET-CT. And yeah, that was a conclusion. And
what was the CPK, ma'am, in this case? CPK?
I don't remember. I think it was normal. Yeah.
Okay.
Yeah, I don't remember the exact values. And he was started on prednisolone. Oral MMF was added only when the liver functions normalized. He had good symptomatic improvement with the above management, but as usual, lost to follow-up, defaulted treatment after 6 weeks. He went completely off medications. He went back to UAE to continue his driving assignment, and he presented back in August 2024 with complaints of dyspnea and cough for 1 month duration.
Were you able to load?
No, ma'am, I haven't actually got it. Again, it's the same one only, old one only is there.
Oh, okay, fine.
The Uday Kumar, I got both the things, but this is the old one only.
So what was the CT scan, ma'am? You felt it was improving?
No, it had deteriorated. Yeah.
Okay.
Yeah.
Okay, it was deteriorating. Do we have a repeat PFT? These are the questions.
Yeah, if you go back to the PFT, August PFT is there.
I'll go back. I'll go back to PFT. CT scan did show improvement. And
did not show any improvement. He was not able to perform the PFT because he was coughing and so dyspneic that he said he can't perform any of these tests. And he did the 6-minute walk test. The distance has decreased. There was considerable desaturation and he was severely dyspneic.
At this time, what medicines were going on, ma'am? Or he stopped all?
He was not on any medicines when he came in August.
Okay.
So we admitted him, ruled out infection by his infection parameters, and we had to give him pulse meter prednisolone because CT had actually showed ground glassing, further deterioration of whatever shadows we were seeing.
Sure. Okay, so this is the question.
So consensus diagnosis was the initial CT pointing towards myositis ILD. And is there any other treatment option other than MMF and steroids? And what is the prognosis? These are my questions.
Okay, I'll just stop sharing and maybe Rajan sir and Umrah, anybody
Yeah.
can take.
So I'd like to know Harjeet's thoughts as well. But, this patient has got such poor lung function, Shobha. I'm surprised that he's not desaturating more or not hypoxic at rest. 11% DLCO is really low.
Yeah.
And he's not desaturating that badly. I mean, he's going till 88, the first time 91, and the next time 88. So I find the lung function not
Echo is
correlated.
normal. Echo is normal.
And echo is
And
normal.
there was some suggestion of cardiomegaly in the X-ray, but nothing in the...
And his pro-BNPs were okay also.
Oh, normal.
And he obviously was prescribed an antifibrotic in the beginning. I'm not sure why, but he reacted to the steroid that time. And then he was given steroids and antifibrotic. Steroids pushed up his sugars, you said, right?
Yeah,
and the
that's
antifibrotic created liver issues. Clearly, this is an OP-like pattern, organizing pneumonia-like pattern to me, and I would definitely give steroids and repeat lung functions to see what we have gained. I would expect good gain here with that first scan. What the second scan is showing, if it's showing predominantly ground glass, that means it's predominantly a reversible component here.
Yeah,
what's the time gap between the two scans, Shobha?
It was in November 23. This is 6 months off treatment. He was completely off treatment for 6 months. Correct. And then he comes back in August 24, last month only.
So why do you say he's got much worse? I mean, I guess he stopped treatment and he's come back, right? Or
yeah, that's right.
Is there any, did the CT people say this is worse than the earlier scan or the same?
It is more than what it was before. We could see more ground glassing.
More ground glassing, yeah. So I think you did the correct thing by pulsing him with steroid to get reversibility. And now it would be good to see NXP2, as far as I know, is not associated with rapidly progressive ILD, but it is associated with malignancies for sure. And you've done the PET scan to rule that out. And so alternative drugs I would only look at once we get a response to steroid here. Rituximab, I think, is something one would think of if one did not get a satisfactory response to steroid. But you said you have got...
Initially he had. This time also, when he went back home, after the pulse, he was feeling better. Definitely symptoms have improved.
Right. Somehow, I think the next drug to use, one will have to sit back and think about this. But I don't know, Mithun, do you have a thought here whether to give Rituxi here?
Here the worsening, whether it was due to whether a patient didn't take the medicines properly, patient had a relapse because he defaulted the medicines, likely.
Right.
Otherwise, rituximab is a very good choice. But if patient has very extensive ILD, giving rituximab upfront, there's a high chance of infections, especially if you are giving with high dose steroids.
Sure.
You are actually knocking out the entire immune system.
Sure.
Therefore, the one thing is we can give the same thing that MMF with steroids. Later and after 1 month or once you taper down steroids, if there is again worsening, we can try for rituximab.
Sure.
That's one thing.
Well, we have got excellent responses with rituximab, but it's the steroid that kicks in, the pulse steroid that kicks in. You give the rituximab with it, and 2 weeks later the oxygen requirements come down. But what is puzzling me is that this patient is 98% on room air. So it's not tallying with the scan, right? I mean, something is a little odd there. Harjeet, your thought here?
So, like the scan and the entire history generates more questions than answers. If you look at the scan, it is like the involvement doesn't suggest an FVC of 30% just by the look of it.
Yeah.
In the DLCO, obviously, the lung does not look so bad, but I think Aparna mentioned this is not a high-resolution scan. So maybe if you have a high-resolution cut, it would look far more sinister than it looks on the plain CT. Plus, the second bit about organizing pneumonia is sometimes organizing pneumonias are notorious in the sense that we believe they are predominantly ground glass and inflammatory and they respond to steroids. But actually, a fair share of organizing pneumonia sometimes are very resistant to anti-inflammatory therapies. They just don't budge even after treatment. But having said that, over a period of 1 year, he dropped from 360 to 300 meters. 300 meters is still a good walk distance for me in our scenarios, because our patients are so sick by the time they come. And the point which you made, that room air saturation 98, not desaturating below 88 even after a walk. So all of this indicates a slowly progressive disease, if at all we consider it as progression, because without treatment, obviously it's going to progress. So he's an untreated patient and it's a slow progression from my side. So it's not behaving as aggressively like a myositis disease would in routine circumstances. Now, NXP2, I'm not sure, I've seen a bit of them, but personally speaking, in most of these situations, if you pick these diseases incidentally, then always there is this debate about you trying to correlate it with clinical symptoms to really stamp it as a patient who has an autoimmune process in the lung. He has no extra pulmonary symptoms. So for me, again, that becomes an issue. Having said that, because this is an NSIP/organizing pneumonia pattern, which I fully agree with Aparna, I won't label it as idiopathic NSIP, and hence I will take that myositis positivity in the loop and then pulse him with steroids. Another question which I had was, because there was a PET done and we use the PET in patients with sarcoid to assess activity, it has not been proven to show effectiveness in other ILDs. But did the PET show uptake in those areas of ground glassing by any chance? Because that would...
It was not there, if I remember.
Because sometimes, although it is not indicated for these purposes, and a gadolinium, if FAPI scan, what I was talking to Bhavin earlier was, those are some things which actually tell us about inflammatory versus fibrotic pattern. But if there was a lot of uptake, I would be tempted to use a lot of steroid upfront and anti-inflammatories. But in this patient, because I was not seeing that, this patient is an advanced disease, FPC 30, DLCO 11%, the debate would be, would I give an additional anti-fibrotic at this juncture as well, in addition to the anti-inflammatory which you have started in this period? Lastly, this patient with fresh ground glass could have had an acute exacerbation. It could be an acute viral process, something like that. So you need to rule out all those things before we pulse them with steroids. 9 out of 10 times, if you did not have an acute prodrome suggesting of a viral illness, then what you did was treatment for acute exacerbation, which I fully agree with. The difference will be that I would go with cyclophosphamide rather than rituximab because of the faster onset of action compared to rituximab and relatively lesser immunosuppression compared to rituximab. That is my only take there. And like Mithun said, that rituximab would be my second line drug if that fails. So those are my bits.
There is one new drug now, Mithun, which we started using, tafasitinib, or what was it?
That is for this myositis ILD, tofacitinib.
Yeah,
Tofacitinib.
Yes. Because for myositis ILD, the recommendation is cyclosporin. Also, you can add 3 drugs if it was MDA5, but this is like a slow progression. So I wouldn't bombard him with 3 drugs upfront. I would be more than comfortable trying out 2 drugs.
Sure.
All those 3 T's, as they say, tofacitinib, tacrolimus, tocilizumab, they're all the new kids on the block in the idiopathic inflammatory myositis. Yeah.
No, but that works, tofacitinib.
They do.
Tofa worked for one MDF5 RPILD. Surprisingly, but it worked in one patient, the second patient didn't work. I don't know. Therefore, it's not a solution.
But we don't use cyclosporin. What do you say, Mithun? No, we didn't use for
cyclosporin is third line or fourth line type of.
We don't use it. Rituximab we have used. Immunoglobulins we have used, but
cyclosporin we have used, but it's little. One is costly. We have to monitor the levels, and side effect profile is also.
Yeah, Murli Mohan sir, did you listen anything about this case? Then please give your inputs.
No, actually, I missed most of the case, but. This triple combination is when it's rapidly progressing. Otherwise, you don't need to consider Ritux. But the few patients we've used Tofa, actually, it's been surprisingly good.
Yeah,
so
it is.
That's certainly an option. The only other thing I was saying is when you have this combination of organizing pneumonia, and I'm sure this was discussed earlier, and an NSIP, myositis comes very high on the list. So I would still push that as a myositis-related diabetes.
Sure.
Yeah.
Okay,
I think, Shobha, if we can get better follow-up on this, because last time I think they didn't follow up. He disappeared to follow up, then came back worse. So I think it'd be great if we can get follow-up, and if he'd be able to do a full lung function then.
Yeah.
And
Yeah.
see
I
how
will.
much,
Yeah.
how much FVC and DLCO you've gained, and then sit back and take a call on, cyclo, mycophenolate. If he's significantly better, probably myco would be enough.
Yeah. I have started him on mycophenolate.
Sure.
Did he improve with pulse steroids, ma'am?
Yes.
Yeah.
Yeah. By the time he was out of the hospital, he felt really better.
Okay. And he was discharged off oxygen.
Yeah, discharged on steroids and MMF.
Sure.
And, so that's some of that 11% DLCO and a normal oxygen saturation. That's somehow just not tallying. I'm finding his FEC and DLCO really low. Yet this man the lowest he drops to was 88. These patients we see dropping to like low 80s, below 80 usually on a walk. I don't know what you feel, Harjeet.
Definitely. I was just also thinking whether there was some neuromuscular component to this entire process, because he didn't blow too well, whether the myositis in any way contributed to the effort, because that 30% FVC was far out of proportion to the CT picture. And I didn't see a lot of emphysema on the CT for me to start thinking in terms of and the smoking history was also very little. So
very
that
brief.
FVC was disproportionately low to begin with. So whether there was any muscle involvement contributing to the restriction.
Hey, Aparna, can you please go through that CT scan once more? Because I remember Athol Wells sir telling me tiny lower lobes. That is what is classical of this thing. Myositis related ILD. Was it tiny lower lobes?
Tiny, sorry ma'am, what was
lower lobes.
Okay.
Also, his CPK was normal.
Normal.
So this is an amyopathic myositis.
Yes, most likely. Most of these patients are amyopathic. So that's why they don't present with the classical symptoms of muscle weakness in most cases.
So that's true.
Nothing specific like that, ma'am.
Okay.
It's but it's having some lower lobe predominance. Yes.
Sure.
Dr. Aparna, can we see a sagittal view of this?
Yes, sir. It's not very good because these are thick sections.
Yeah.
This is the one side. This is the other side.
It's really not very much reduced.
You can't say tiny lower lobes. Everything is small.
Yeah.
Okay.
The other thing is you have to be very careful about the 6-minute walk distance, because I'm just coming from seeing.
Hello. We lost you, sir. Okay. I think I'll share my screen.
Is charging ahead at 5 speed. So a lot depends on how much they want to walk and, show it. So sometimes you can be misled by the 6-minute walk.
That's a good thing to know. So I'll just share the screen for the last case. We are already 6 o'clock. Madam.
Yes, 59-year-old male. He's a resident of Tripunithura, that is near Kochi only. He works as a security guard. He's a reformed smoker. He stopped only 4 months back. Comorbidity is systemic hypertension. And he presented to AIMS in December 2023 with productive cough since 1 year, progressive breathlessness since 1 year, progress from grade 1 to 3 MMRC. And he has a pet dog in the house for the last 6 years. He had pigeons in the house for 4 to 6 years. That was about 8 to 10 years back. But at that time, he had no symptoms. Again, he had exposure to pigeons at the workplace since 3 years. Now he's not exposed to the pigeons. And he had 3+ clubbing. RA factor was positive. ANA 2+ fine speckled. And ANA profile was negative. And these are his PFT. So ratio was 0.81, FVC of 1.75 liters, DLCO was 15%. He walked 360 meters. There was a desaturation from 94 to 82 with 3 plus dyspnea. That was when he came in. And yeah, if I can have the CT.
Yeah, 1 second. I'll just stop sharing. Okay, Aparna.
Yes, ma'am. So this one's we have 2 CTs. This is on November 2023 and this is in August 2024. Again, one of it is HRCT, one is not HRCT, but we'll see whatever we can. So this is the initial CT. So we are seeing ground glass reticulations, traction bronchiectasis, and it's very heterogeneous kind of involvement. Some areas are involved, some big areas are completely spared. So upper lobes, there is significant involvement. And again, there is some big area of right middle lobe, which is completely spared. Lower lobes, superior segments are involved, but the bases are relatively spared. But in the bases, there is some mosaic attenuation with some lobular areas of air trapping. Pulmonary artery is very much dilated, 36 millimeters. Not much of RARV dilatation. There was a small paratracheal node, this one, which is around 13 millimeters. Maybe it's just a reactive node. Yeah, those were the main findings. Compared to the previous one, the present one in August, there's little difference in the technique, but it's more or less kind of similar. So whatever looks like little increased density, it may be because of the difference in technique, but the distribution is same. And there's not much worsening in the fibrosis also. It looks almost similar.
So you think there is no worsening CT-wise? Okay.
Yeah, I'm just saying within whatever I can say.
Yeah. Okay. I would like to go back to the PFT slide and.
Yes, ma'am.
Aparna, can you show us the coronal sagittal cuts of that first scan, if possible?
Sure, sir.
And there are no inspiratory, expiratory phases?
No, it was taken before we saw the patient, so we have not got expiratory cuts.
Sure, ma'am.
This is the coronal. This is of the first scan. So the bases are relatively spared. Yeah. And sagittal. Again, there are like big areas which are completely spared. Again, the bases are spared.
No fissural nodularity, no, that you're seeing?
No, sir. No.
The second scan, to my eye, looked more fibrotic, but you're saying that the imaging was different quality. The acquisition was different, right?
Basically, these are thick sections. These are not the proper HRCT.
Sure.
So I'm not very sure, but it's almost same, I think. If at all, I don't know whether the ground glass component has slightly increased, but I am attributing that to the thicker sections.
Right.
I'll just show the PFT once more.
Or can I have the questions and then?
Yeah, sure, ma'am.
Yeah. So first will be what is the diagnosis, and
based on CT, I would think of like hypersensitivity with that pigeon exposure history also that you said, and the bases being completely spared.
Yeah, that's what we also thought. And the patient was started on steroids, and the thing is there is funny thing going in the PFT and on his follow-up. So his improvement, his dyspnea completely subsided. He walked 420 meters within 1 month of starting steroids, but his FVC deteriorated. I'm not able to explain that. Then In March, we were still continuing steroids, but slightly less than what I started. Then his FVC improved to 55%. And that time he had severe dyspnea on walking. But he still managed 420 meters and there was desaturation. Then he comes back in May. Again, FVC is 1.75 liters, 420 meters. His desaturation has reduced. He has no dyspnea. That is when he stopped coming to the OPD for review, and then comes back in August with the further increase in dyspnea. At that time, FVC is low, but no dyspnea on 6-minute walk test. He walked 390 meters, but there was significant desaturation. I'm not able to explain why this kind of disparity in the FVC when his dyspnea disappeared and
Well, I think he's on the lung function, Shobha, he's definitely declined. I think he's adapted his life to his dyspnea, which happens very often.
Okay.
And that's why they don't complain too much on the test also. He's been desaturating right since November 2023.
Yeah, that's right.
And significant desaturation. Now the vital capacity has dropped significantly, I think more than 10% now. So that's obviously a sign that he will need an antifibrotic, in my opinion.
And
how much immunosuppression you give here is a question, because with immunosuppression, he seems to be getting worse. So to me, the antifibrotic would be priority here.
Okay. So any steroid sparing agent, is there any indication for that?
Is he any comorbidities that would
only hypertension? He's not a diabetic.
And he's 59 years old.
Yeah.
Right?
He still works as a security guard.
Right. So you could consider mycophenolate, but to me, that is not as important as getting him onto an antifibrotic. I think that would be priority. Immunomodulation hasn't helped him, so I think we should hope that it doesn't harm him now. And that could create problems. But a low dose of steroid or mycophenolate, giving them both together, at least in this patient, I wouldn't be keen to give both together, either one. And once we have Sejal's data out of the MycoHype trial, we will know which is better, Myco plus steroid versus steroid alone. But till then, I think I would just use one low-dose immunosuppression in such a patient. Murli, Harjeet?
The first bit is that the fluctuations in the PFT, this gentleman has been a smoker till 4 months back. So that's a component of airway disease contributing to the fluctuations with acute worsening in the airway component rather than the ILD component, because the ILD looks pretty stable on the scan. So that could be one thing which I'd look at, and maybe some inhaled bronchodilators to see whether it makes a difference to his breathing difficulty. And if it does, then there might be a component of significant airway disease there. That is the first thought. The second bit is I feel by the second scan, there is development of pulmonary hypertension. I definitely feel there because he's hypoxic more. The worsening in the FVC obviously could have contributed to the worsening in hypoxia, but I believe the pulmonary hypertension has set in. And that could be the reason why he's desaturating more and symptomatic more. That was the second bit, because we don't have an echo at the second time. So get an echo done to see how bad is it.
Yeah, right.
The third part is that I'm not convinced about the HP diagnosis, frankly speaking. And that is something which I would debate, in the sense, obviously there is exposure history. But for me, a non-fibrotic HP to begin with, because the first scan was predominantly ground glass and, stuff which was not predominantly fibrotic. I would possibly have expected some element of ill-defined central lobular nodules, which is the classical finding of HP. And this is more of ground glass organization, I feel, rather than, what I would expect from an HP. Now, with that ANA2+, I would still run the myositis panel here, because I would want to see whether there is an autoimmune component. Why that helps is because that question of yours, whether any steroid sparing agent, autoimmune panel coming positive, it would give me a justification of a second agent, and I would have a choice of several agents to choose from. So, and that possibly would be a clincher for me if I get some positivity on the autoimmune process. I fully agree about the antifibrotic at this juncture because he's lost FVC on steroids, and now he's in that borderline zone where I would not wait and watch too much. So even if his FVC improves after giving steroids or maybe an anti-inflammatory agent, the antifibrotic still should be pursued aggressively because he's behaving more like a fibrotic process rather than an inflammatory process. He's worsening on steroids. So obviously that helps.
Okay.
Yeah, so I partly agree with Harjeet. Not on the diagnosis. I still would put HV as my first diagnosis. Upper lobe involvement, lower fibrosis in the beginning, history of exposure, and that very variable appearance. I would really have liked to see a inspiratory, expiratory film, see if there's air trapping. And I still think it may be worth persuading to have that done. The second point on why he's worsening, he said pulmonary hypertension. Totally agree with that. I think that's, very high on the list of possibilities. And that's the first thing that we need to rule out before we embark on, a second agent and so on. But I'm more inclined, and I would completely agree. I think we should also rule out an NSIP. You were starting to see some central traction dilatation. So we should rule that out. We should do a myositis profile. So I don't think the diagnosis of HP can be taken for granted, though I still think that would be top of my list. And last of all, I know there is no evidence for prednisolone alone versus prednisolone with MMF yet, but our own experience has been that you can bring down the dose of steroids, and that, to my mind, completely without evidence is still justified with careful monitoring. And last of all, I check whether this chap has had, again, some exposure to pigeons, which has again made him worse. So that I would, that's history, and I would like to ask him, is there any way you got exposed to this again?
Yeah. So last time I discussed one security guard who was working somewhere in Gulf countries, and he was doubling as a cleaning staff, and he told me that the flat which he was working, there are many pigeons. So maybe it will be worth asking that question, ma'am, because there was his job was security guard, but when I specifically asked that, do you have any exposure, then he told, yeah, he does a cleaning also where lots of pigeons are there. So what sir told is correct. And we didn't send myositis panel, and we can repeat the echo also. Those things we can definitely do.
I think I must have sent the myositis panel.
Then it must be negative. Yeah, it must be negative. So it has not been put, because that is our standard workup that we send myositis. That was why I checked it again, that myositis panel was not there in the slides. So maybe we can cross check with that. And the treatment part, can we have a consensus, because everybody is having difference of opinion. So madam will get, so steroid has to be continued, and steroid sparing agent in the form of MMF has to be added. Is it right?
Yes. Antifibrotic
now.
Yeah. Okay. Ambulatory oxygen. Rehab.
St. John's.
Yeah. Right. And rehab, and he's may have to be counseled on transplant if you have that option. But these are patients who, if they can afford it or have access, we would counsel for transplant.
Sure.
Just anecdotally, we have a very senior orthopedic surgeon, one of the leading orthopedic surgeons in the city, who had classic hypersensitive pneumonitis, Ravi Mehta's patient. They even did a biopsy, and that was very strongly suggestive. But he swore that he was not exposed to pigeons or other birds. And then after the diagnosis was reached, he sent them photographs. His house is filled with all kinds of exotic parrots. And he had to wait till his biopsy was done, and they were insisting, no, this is HP. And then he sends him these pictures. So even senior doctors, you cannot rely on to give you a good history.
No, you asked for pigeons, sir. You didn't ask for parrots.
They asked for birds.
No, in fact, when Shobha put up he had pigeons in his home, I thought he had pet pigeons first.
Oh God. Yeah, it's all funny things which patients say most of the times, and as you told, even doctors are not spared out of it. We are very specific and focused about the questions which are asked to us. I think that's it.
The gentleman is clubbed. He's clubbed. He's severely hypoxic on ambulation. So he is far out in his disease here. Yeah,
I think chronic HP, chronic HP only behaves like that.
So he is going to probably continue to progress.
Sure.
And I think the clubbing sort of correlates with that drop in FVC. He's more symptomatic. I'll probably get the antifibrotic on for sure.
Oh, yes.
These are the patients you wouldn't want to wait on that and counsel them.
Yeah, I think that's it, folks. Thank you so much. And tech support, can we please make it offline?
Thank you.
Yeah, 1 second. Can we make it offline, Manish? Manish is not there. Make it offline. We are done. Thank you so much, all those people who have joined us. Thank you. Can you make it offline, Manish? Are we offline?